Hi, I'm Nicole Maresca.
And I'm Whitney Bryant, and our Capstone project is why children born with cleft palate are often not detected and referred.
We will be using a survey to acquire information concerning the knowledge and experience of pediatricians pertaining to the evaluation and treatment of children born with oral clefts, and more specifically, cleft palates.
With this study, our hope is to decrease the risk of late detection in those with cleft palate and increase the rate of referral to craniofacial teams. To give you a brief overview of cleft palate, it is a highly prevalent abnormality in the oral cavity affecting the hard and/or soft palate. Researchers believe that orofacial clefts are caused by a combination of environmental factors and genetic predispositions.
Pictured here on top is what a normal palate should look like in an infant. Below that is a depiction of what an infant's oral cavity with cleft palate may look like. Generally, we divide orofacial clefts into three categories: cleft lip with cleft palate, and cleft palate only. We then further divide cleft palate only into four separate grades. As the grade number rises, the magnitude of the cleft rises.
As you can see below, grade 1 is a submucosal cleft palate, which is usually identified by a bifid uvula. Grade 2 is a cleft of the soft palate only. When there is a cleft of the soft palate along with a third or less of the hard palate, it is known as a grade 3 cleft. Lastly, when there is a complete cleft of the hard and soft palate, it is called a grade 4 cleft.
The first article we chose was The Late Detection of Cleft Palate by K. H. Haney and fellow authors. The purpose of this study was to investigate the age at which cleft palate is diagnosed in large tertiary hospitals and how the extent of palatal cleft, the presence of syndromes, and the gestational age and the location of infant delivery relates to age at the time of diagnosis and the occurrence of cleft palate.
To complete the study, the researchers examined medical records of 271 consecutive patients with cleft palate, whom were treated by the Wilhelmina Children's Hospital cleft palate team between the years of 1997 and 2014. They excluded all children with oral cleft other than cleft palate only, and all adopted children due to lack of maternal and neonatal information.
The results of the study showed that 52.7% of the children in the study were diagnosed with cleft palate only within the first week of life. In the second week of life, 3% of the population sample were diagnosed. In the following third week, 3.7% were diagnosed, and in the fourth week, 3.3% more were diagnosed. The remaining 37.3% of the population sample were diagnosed after 30 days of age.
In the patients diagnosed after 30 days following birth, 62.6% were subsequently diagnosed with a submucosal cleft palate. The remaining population is then divided between cleft grades 2 through 4. As the grade increases, the percent of those diagnosed decreased. The strengths of this study can be seen in its internal and external validity. The researchers used multiple statistical analysis which further support their findings, and the study had a large population size in comparison to similar studies which had relatively small sample sizes.
Despite its strength, there were a few limitations to the study. While external validity is a strength, in contrast, it is also a weakness. All of the data was taken from patients registered with the Dutch Cleft Registry, which may have resulted in a skewed incidence rate. Furthermore, the collection of medical files spanned from 1997 to 2014. During that time, it is quite possible for changes to have been made in the standards and guidelines for neonatal screening or in oral cleft exams. This may have skewed the results.
While our first study looked at late detection for all degrees of cleft palate, Dam and a team of authors investigated the age of diagnosis and evaluation of the consequences of cleft palate, specifically discussing submucosal cleft palates in the article Age of Diagnosis and Evaluation of Consequences of Submucose Cleft Palate.
The aim of their study was to compare the reason for suspecting a submucosal cleft palate, age at diagnosis, the effect of age on speech development, speech, hearing, and swallowing of all patients of the Groninger cleft palate and lip team whom were diagnosed and subsequently treated with the submucosal cleft palate over the past 20 years.
33 patients diagnosed with a submucosal cleft palate were registered with the Groninger cleft lip and palate team between 1990 and July of 2012. 5 of those 33 patients were excluded from the study due to lack of follow-up data or the presence of a comorbid syndrome. All patients were comprehensively evaluated by an otorhinolaryngologist, speech-language pathologist, audiologist, plastic surgeon, and child psychologist, whom were all members of the Groninger cleft lip and palate team. Following the evaluation, appropriate treatment was administered to participants following the Groninger cleft palate team's protocol.
They found that within their sample population, children younger than 1 year and 2 months old presented with swallowing problems initially, particularly nasal reflux, choking, and difficulties with drinking. Their older patients initially presented with hypernasality, imprecise articulation, and eustachian tube dysfunction, with conductive hearing loss and/or swallowing difficulties. However, at a younger age, these patients had swallowing difficulties that were brought to the attention of their pediatricians. Little or no attention was given to these complaints, suggesting that it may be thought that swallowing problems are innocent and may improve over time.
More than 90% of the sample's patients presented with a bifid uvula, and 83% of those patients received an adenoidectomy, tonsillectomy, and/or ventilation tubes before diagnosis of a submucosal cleft palate. This suggests that medical professionals may be performing inadequate evaluations or that they may not be aware of the implications of a bifid uvula. Hypernasality was present in 65% of the sample population. Following surgical intervention, hypernasality was no longer present. 39% presented with conductive hearing loss. However, 67% of them saw improvement following surgical interventions.
The strength of this study can be seen in its eternal validity. The study's data and interpretation are in agreement, which results in a credible and defensible conclusion. Another strength is that patients were provided a comprehensive evaluation by a complete cleft team.
Limitations of the study include its sample size and longevity. Being that the sample size is only 28 individuals, the participants may not be an apt representation of the overall population, which is a threat to the study's external validity. Furthermore, the researchers developed their sample population by taking patients of their cleft palate team over the span of 20 years. Within that time, protocols for evaluation and treatment may have been altered, which would subsequently skew the results of the test and threaten its reliability.
In our last article, Teleeducation about Cleft Lip and Palate, an Interdisciplinary Approach in the Promotion of Health, Camilla de Correa and other collaborating authors examined the use of telecommunication instruments to build student awareness and ultimately promote health education. This descriptive study aimed to calculate the students' increase in knowledge after participating in the training program about cleft lip and palate. An invitation to the study went out to 50 students deemed appropriate for the training, in which 9 students indicated they weren't interested, and 41 of them chose to participate. Of those students partaking, 16 were boys and 25 were girls.
The researchers designed an exclusive training program they called the Young Doctors Project, which used multiple modes of technology to educate students on the different areas of health and wellness. The same questionnaire was given prior to the training program and following it. The setup followed 3 key parts: interactive teleeducational classes, a cyber tutor, and online activities promoting learning. Researchers found that following these 3 guidelines improved overall performance on the questionnaire and increased the students' awareness of cleft lip and palate. Here you see the results of the study show a significant increase in all topics of oral cleft, with the exception of social aspects, which received a 100% correct results on the pre-testing and post-testing. The chart shown on the left is broken down into topics of oral cleft and gives the researchers a better understanding of what areas need further education. The graph to the right is divided into the top 5 most improved questions. This gives a good understanding of what topics of oral cleft were best retained by the students.
The article was evaluated, and we concluded that it did in fact have some strength as well as some weaknesses worth mentioning. For instance, each student answered a wide variety of questions such as embryology, etiology, key definitions, treatment, and other important aspects of cleft palate. Another positive attribute of the study was its use of more than one technological resource for learning. The program creator chose to use a 3-step teleeducational process for acquiring information instead of a single arrangement of materials. Students gather information differently, and this feature allows them to gravitate towards and learn from one of 3 different approaches to the training.
On the flip side, the article includes some weaknesses of significance. The author claims that the overall training program, quote, provided an effective tool in the promoting health education. Due to the lack of variety in participants, this claim does not take in account other members of the community and assumes the process would be effective with all promotion of health education. This is an example of homogeneous population sample and could skew the overall results of the study. Secondly, the researchers, who obviously developed the study layout, chose not only to provide the questionnaire, but to also give the lecture to the students. This is a prime example of researcher bias and could absolutely skew the results.
Many studies have examined the effects of late detection of cleft lip and palate and the timing of surgical intervention on the speech and hearing of children, as well as the model of delivery of knowledge regarding cleft lip and palate. It has been made clear that the timing of detection and intervention plays a distinct role in later development. Despite this knowledge, little information is available regarding pediatricians' knowledge of oral clefts and the rates of pediatrician referrals to craniofacial teams. Within the state of North Carolina, there were 180 infants born with oral clefts in 2010. Most of these infants were born in the western and northern portions of the state. With this many incidences of cleft in North Carolina, it is important to know if our pediatricians are prepared to serve their patients.
The purpose of our study will be to assess pediatricians' knowledge of oral clefts, particularly cleft palate only, and why children are being referred later on in life. The aim of the study will be to answer the following questions. 1. What do pediatricians know about cleft lip and palate, including its detection and intervention? 2. Why aren't those with cleft lip and or palate being referred to craniofacial teams earlier on in life? And 3. How would pediatricians prefer to receive further information regarding cleft lip and palate?
To complete this study, a survey will be distributed to pediatricians throughout the state of North Carolina. The survey will consist of 3 sections. Within the first section, participants will answer questions regarding information about their place of work and current training levels regarding cleft lip and palate. In the second part of the survey, participants will answer questions regarding the current knowledge of cleft lip and palate. Within the final section of the survey, pediatricians will provide us with information regarding areas within the realm of cleft lip and palate that they would like to or feel they need to learn more about, and how they would like to receive this information.
The information garnered from this study should result in multiple implications for the detection and intervention of cleft lip and palate. To begin, it is important to know whether or not pediatricians have the knowledge required to accurately assess the presence of oral clefts, specifically cleft palate only, and then subsequently refer them. Secondly, it may provide valuable information as to why individuals with cleft lip and or palate are not being referred to craniofacial teams at an early age. Lastly, the study will provide us with information regarding what areas pediatricians feel they lack knowledge in cleft lip and palate and how they would prefer to receive this information.
These are the resources we used for our presentation.